Hey there, and welcome. I'm Anna Hartman, and this is Unreal Results, a podcast where I help you get better outcomes and gain the confidence that you can help anyone, even the most complex cases. Join me as I teach about the influence of the visceral organs and the nervous system on movement, pain, and injuries, all while shifting the paradigm of what whole body assessment and treatment really looks like. I'm glad you're here. Let's dive in. Hello. Welcome back to another episode of the Unreal Results podcast. Here we are in my office, in my new office. Y'all have seen it before because I've recorded a few episodes now here, but officially like a little cleaner. Still need to hang pictures on the wall, but we're getting there. And I'm officially filming this from standing with my new standing desk. So that's fun. Still dialing in the sound and stuff, but we'll get there. Today, I wanted to share a really practical episode. I know people ask me about what to do for elbows a lot. Elbow pain can be tricky. And now this episode is not on elbow pain. But it reminded me of that ask because this episode is going to be on ulnar nerve and hand pain. Currently, my ulnar nerve entrapment hand pain. And I figured I was getting ready to treat myself, and I was like, you know what? I should probably just film this whole thing as a podcast episode and let you know sort of what I do and my thought process is because this week I've actually been able to make some good progress on it. Mainly because also I had a kind of a week off from seeing a ton of patients that I've been seeing. So it just gave me the space to work on it, and then also didn't add on a bunch of manual therapy on it. So I wanted to share about this. If you're new here around, you might not know I have a whole course called Never Treat the Shoulder First. It could easily be called Never Treat the Upper Extremity First. Rarely is your body in a protective pattern around something going on in your upper extremity. Frankly, your upper extremity is just not that important. It just doesn't influence. It's not that it's not important. Upper extremity is super important, right? Our hands are really important, but it doesn't influence the rest of the body quite as much as if something was wrong with my foot or my leg or whatever. So, and it's definitely not as important as the viscera and the nervous system. So, with that said, there's almost always, I don't even know why I say almost, there is always a more proximal driver to any upper extremity issues that you need to figure out where it's coming from in order to have the best treatment outcomes for things going on in the upper extremity: shoulder, arm, elbow, forearm, wrist, and hand. So that's what I want to share with you. Knowing that, I want to tell you a little bit of history of what, also what's happening with my arm. So, in my past history, I've had ulnar nerve radicular pain, whether it's coming from my neck or, who knows where that original insult was, but I'm left-handed. I was having left radicular pain for a really long time. And this was sort of earlier in my career, didn't really see the body from a more whole organism standpoint. And so I struggled with it for a long time. And then as it's come back, as I've learned things throughout the years, I did also, I've learned very common entrapment areas of the ulnar nerve itself, which we'll go over today. And the common entrapment areas of the ulnar nerve obviously are going to be in the upper extremity. So we want to know those because eventually we're treating those spots too. It's just rarely the main issue is coming from there, which from the medical diagnostic field, this would be referred to as almost like a double crush syndrome type thing, meaning there's something going on up in closer to the cervical spine and then also distally too. And So that's exactly what's going on with me now. So a little bit of for years, like the last time I had some ulnar nerve issues was 20, I don't know, before COVID. Or maybe after COVID. I don't know. It was years ago. I remember I was in Hawaii when it was bothering me. And that's when I learned about one of the entrapment areas. But it's been many years since it was bothering me. But about 2 months ago, I started having really significant pain on between my third and fourth metacarpals, kind of at the metacarpal phalangeal joint area, and then even into the space between the fourth and fifth. Even palpating, I'm definitely numb there, more numb than the other side. So diminished sensation, mostly along the metacarpal and the dorsum of the hand. And then it was just getting worse and worse to the point that, like, if I put my hand behind my back to like put my backpack on or off, I'd get like a really sharp zinging pain in my hand. If I pushed open my door, if I was gripping something in my hand and push open my door with the dorsum of my hand, if it hit the area of the ulnar nerve, I about wanted to jump through the roof. Very tender. And then creating that zinging as well. And then it's just the more it went on, the more like everything in that elbow flexion and wrist flexion position started to bother me quite a bit. And then any sort of sensation to the skin, whether it was with my hand or anything else, whenever it touched it, was very sensitive. And then finally progressed to this like actual diminished sensation that I've been getting lately, which is kind of just like a dull feeling all the time. Now, back up a few weeks ago, earlier in August, so like almost a month ago now, when I was in New Orleans for the Fascial Research Congress, I, note to self, still need to film that episode for y'all. They're synopsis. But anyways, I was there, and two of my colleagues that I trust very much with caring for my body were there in one of the sponsors' booths in the EQ Flex Wave booth. Dr. Sean Drake and Kiki Cordero Drake. Sean is a chiropractor that I know really well out in Arizona. Kiki is a PMF and Pilates practitioner. Also, they own the business Modern Athlete. So anyways, when I was there, I was like, oh, I love you guys so much, but also, can you take care of me? Because I'm having this nerve pain. And they both treated me. And Kiki actually is one of the LTAP alumni as well. So she knows that it doesn't start in the arm. And so she treated me, and through her experience and knowing the LTAP, and then just her clinical experience and using the EQ Flex Wave, she was really directed to my cranium and face, neck. And it made sense because right before or right around the time when my nerve symptoms started bothering me, it was right around the time when my nerve symptoms in my tooth started bothering me. So I had a pretty I had like decay underneath a crown that really inflamed one of my nerves, and that has been a journey. I still have a little bit of nerve pain from it, but the nerve is finally calming down after like 8 weeks from when I did the crown to fix it, and that's on top of like probably a month before that when I was having symptoms. So anyways, when she treated up there, it made a significant difference on how I felt. And then Sean treated me, and he manipulated my radial head and then manipulated my wrist. And both of those things helped quite a bit too. But then it was not fully gone. It was still kind of there. And so now I'm back to treating myself and figuring out sort of like what to do. And so it's no surprise that I got relief from the cranial stuff. So that is where my protection pattern is currently. So those of you who have taken the LTAP, you know how to get there. But basically, my SI joint was hypomobile, but when I held my breath, it became mobile. And then I checked for my CNS tension pattern, which is through the protective pattern, which is the mastoid process prominence and the sacral position. And I was side bend to the left. And so that's indicative of a central nervous system protection pattern on the left side. And so first I direct my treatment there, but then also it's like before I want to treat the area, I want to see how it's going to relate to my pain. And so, you know, I want to take a second to like look at some range of motion stuff. So basically you can see my hands here. The left arm is the one with the writing on it, because I'm going to show you how where the nerve goes. But I'm lacking a little bit of supination and full flexion, as well as a ton of pronation. I'm definitely lacking more pronation than anything. You can also see it here. So pronation, I can't get quite as, so my right arm just keeps on going. My left arm does not, and I start to get a little bit of symptoms into my wrist. And from a flexion standpoint, I also am limited in flexion. This is telling me that I'm definitely like the mobility between how the radius moves around the ulna is lacking. And then we'll just look at extension. My extension on both sides is still pretty good. So I'm definitely not missing any extension. If we look at our my carrying angle, we'll see if I can angle my camera down a little bit. So you also see my carrying angle on this left side is way wider than my right side. This is also indicative of a radius that is not moving so well, positionally not happy. So then we can test some ulnar nerve tension. So how do I get this in the camera? So if we just do a traditional like upper limb neuro testing, we do a little bit of wrist extension first. Oops. You can see I don't have a lot of wrist extension, and here we'll go down by my side. Wrist extension is lacking even without a ton of nerve tension on it. I mean, I get nerve tension right there, but as I go out, I'll tell you when it really starts to increase symptoms, right about there. So that's like of shoulder abduction, like maybe 10 degrees. Whereas on my right side here, you see I'm closer to full extension, though a little stiff on that side too. And then as I go out in shoulder abduction, I don't really get a ton of neural symptoms until maybe 60, 70 degrees of shoulder flexion. And then if we look at just classic ulnar nerve, I'll do my right side, the old Batman eyes move. So this is requiring shoulder flexion, shoulder abduction, elbow flexion, pronation, and wrist extension. And finger extension on the sides that are ulnar nerve specifically, so the last 3 digits. I can do it on the right. I do have some nerve tension, but it's not like adverse. It's pretty like a lot of people may have some tension there. And then when we go to my left side, you see how I'm struggling to even get my elbow up in as much shoulder abduction and flexion, and to try to even get the pronation. In order to do this, I have to bring my hand, you see how I'm trying to bring my head to it? So lacking quite a bit of range of motion there. We could do more of a Z Health sort of ulnar nerve glide, which is going to be wrist extension, elbow flexion, and then come up. And you see there, right as I go that, like I can't come up into I can't keep flexion. I go into abduction to accommodate. Whereas on my right, we go wrist extension, elbow flexion, and I come straight up. like that waitress position. Can't do that on my left arm. So definitely a very unhappy ulnar nerve. Definitely some limited mobility in my forearm. And also, like, if you feel my forearm, both of them feel like I've been doing a ton of manual therapy lately, which I have been. I have a group of 7 Navy SEAL candidates that are definitely requiring a lot of manual therapy and like have me feeling it. So now we have our pre-objective check-in. We know where we're going to start treatment in my cranium. I cheated a little before I started the video, and I treated my left side of my cranium already. And as I told you what I was feeling here, I already know that I now have some right-sided tension that I need to treat. But it's also one of those things in the cranium. You can treat both sides. There's a lot of redundancy. And so we're going to do it. I know a lot of it is from my teeth, and so we're going to treat it from a mandibular nerve branch standpoint using the trigeminal nerve glide. Oh, the other thing I wanted to see was cervical side bending. So, because before I get into treatment, let's talk about the anatomy a little bit. When the ulnar nerve specifically comes out of cervical root C8 and T1, and it becomes it goes on from those nerve roots, becomes the medial cord. Yeah, medial cord. And then the ulnar nerve is one of the branches of the medial cord. Medial cord comes down the inside of your arm here. In the arm, it is just one nerve. There's no branches off of it. It goes through the arm, through this area about 4 fingers above the medial epicondyle. It hits a area of fascial, like septum-ish area, like a fascial container called the arcade of Struthers. It's basically a ligament that the nerve travels underneath. That's the first common entrapment site. That would be considered cubital tunnel syndrome, that entrapment site there. Well, let me back up. That's not just the first site. The first site's going to be the neck itself at the foramen of the nerve roots. Then it's going to be the scalenes, retroclavicular space, first rib, where the brachial plexus goes through, right? The trunks, the roots and the trunks, right? Remember our old school brachial plexus acronyms. And then through the clavicular pectoral fascia, that's where those cords are. That's another spot that can be entrapped. And then as they enter that axilla area, out of that clavicular pectoral fascia, now we're into the fascial containers of the arm itself. It could be entrapped there too. It's a less common spot. Until you get to that area 4 fingers above the medial epicondyle, which is the arcade of Struthers, that ligament that it goes through as it exits those containers and travels to the forearm around the cubital tunnel. So the cubital tunnel is the arcade of Struthers all the way past the medial epicondyle around the true cubital tunnel, which is the ligament that holds the ulnar nerve around the epicondyle there. And then as it goes to the groove, and then it goes another entrapment site at the end of that area is the pronator aponeurosis, a very common spot for nerves to get entrapped in that flexor bundle, basically. And then the ulnar nerve travels along the ulna, around the flexor carpi ulnaris, all the way down to the wrist. At the wrist, it throws off a branch just proximal to the styloid process that goes dorsal. That's a dorsal cutaneous branch of the nerve root. And then the ulnar nerve. And then the other one stays on the ventral side and goes through around the hook of hamate through a canal called Guyon's Canal, which is another possible entrapment site. So Guyon's Canal is an entrapment site. And then you have a branch that goes from that area around Guyon's Canal, around the hand, that also comes to the dorsal surface as well. So any of those areas can be entrapment sites. The nerve as it travels around the area even of the carpal tunnel and flexor aponeurosis, palmar aponeurosis. I was like, why can't I remember that name? That can be an entrapment. The Guyon's canal can be entrapment. And then just within the compartment itself with the flexi carpi ulnaris can be an entrapment site as well. So many spots that the ulnar nerve can have adverse tension and have influences that are going to limit its ability to slide and glide within the container. I drew it on my arm with a green Sharpie as best as I could. It's hard to draw on yourself some, but I started it basically at the arcade of Struthers. You can feel it. It's like a tender spot. It's like a spot where even on a healthy person, you don't want to be like pressing on that spot. It hurts. So arcade of Struthers comes through around that medial epicondyle, along the ulna to the wrist, and then I washed my hands so it kind of washed off. But we got one branch coming around the styloid process and medial, stays medial, and then this branch coming through around the hook of hamate and going to the hand, right? We've got branches going to the hand. Okay. So, where part of the thing too, when you're lacking, well, when the radius is like not in a very good position, when it gets kind of out of alignment, it means that you don't get really good pure pronation. And so you get like a big arc of motion of pronation, and it requires even more length and gliding of the ulnar nerve. And so cleaning up that radius and cleaning up that pronator range of motion is going to be really important. So when we were looking at lacking pronation, we're looking at the opposite muscles being kind of some of the drivers of limiting that, which is going to be the supinator. It's a really common muscle to be limiting. The biceps, it's also a main supinator muscle, right? And then even though it's a pronator muscle, the area of the pronator teres down here sometimes just get like it just is not able to do its job so well because it gets kind of like bound up. And so that's another like common spot to do some treatment on. The thumb muscles can be a big limiter to pronation as well. And what else? Mainly the supinator there. Like, and again, like a lot of times, because it's not the common entrapment site for it, I don't think people treat it very often in this case, but it is a big driver of the problem and the lack of mobility. So you're going to see me treat all of the above. And I'm like, how we even got to this anatomy is because the other thing I wanted to check was my cervical side bending. So you see when I side bend to the left, it's very limited. I get like a little bit and then my head wants to rotate. Where when I side bend to my right, I have a lot of rotation. So one of the main limiters to that, and you can't, it's not just something you see. It could be many things in my neck, but I can feel it on me. My first rib is not moving. This makes sense too when you think about my ulnar nerve because of those nerve roots. C8, T1, rib 1, scalenes. That's the piece. But this is also how it relates back to the cranium, right? Because we said that where my protection pattern is in my central nervous system, specifically some cranial tension, maybe from some of my dental issues going on, trigeminal nerve. Even though you're like, how does that relate to the scalenes in the first rib? Because the trigeminal nerve has a relationship to the meninges. It's one of the nerves that innervates the meninges. And as well as anastomosis with branches of the cervical plexus. And the cervical plexus shares a nerve root with the brachial plexus. So even though it's on the other end of the nerve root from the ulnar nerve, the way it influences that part of it is, one, there's a lot of redundancy in these nerves, the way they anastomose and talk to each other. But then two, because even if the beginning of the brachial plexus, the upper part of the brachial plexus is getting funky messages from the cervical plexus, the muscles in that area tighten up to protect it. And then now we're looking at the scalene muscles, because we know the scalenes go that whole length of all of the roots of the brachial plexus. And so when the brachial plexus is not happy, the scalenes tighten up. And when the scalenes tighten up, we're going to have limited first rib mobility, aka we're going to have an elevated first rib. And so a rib that is stuck in elevation and not depressing, which is what it needs to do when I side bend to that side. When I side bend to this side of the rib needs to get out of the way. Okay? So that's what I feel even when I side bend. It doesn't feel like an upper cervical limitation to me in my body. It feels like down at my thoracic inlet. Okay. So first step, we're going to treat the trigeminal nerve. I'm just going to do it, like I said, the mandibular branch. And so I'm going to do it through nerve glide. To do a nerve glide there, we're going to get capital flexion first, right? Upper cervical flexion. And then I'm going to side bend away, going to stick my head out, protract, and then I'm going to slightly rotate, and then I'm going to play around my jaw until I feel a little tension or stretch along this inferior border. And so I'm going to stick my jaw out and then to the side. I like out and a little more rotation. And then once I get it, then I'm going to do some sort of flossing. I can do it with the jaw itself, or I can do it with the head. I'm going to do it with the head today by nodding. And that's... I'm also feeling like I need to do some rotation, so I'm going to add some rotation in. If you've seen the trigeminal nerve, you know there's so many branches, which means when we do trigeminal nerve glide, there's so many options. Okay? There's so many options to do. So after I do that, I'm going to just recheck my side bending to the left. Oh, that's nice. Now I just feel a stretch on the right. I don't feel that jammed up feeling on the left side. But I'm also going to recheck my mystoid process, and that's actually much more level. There's not a prominence. But because I felt a little bit of a sternomastoid stretch on the right side when I did that, I'm going to do an accessory nerve glide on my right side now, which looks very similar to trigeminal nerve, but we're going to add in the shoulder on it on the right. So I'm going to do that upper cervical flexion, side bend away, depress the shoulder, retract the shoulder, stick the head out, and nod. And I'm going to do just 6 of those. And then relax. And then we'll recheck the side bending. And when I recheck the side bending, that's nice. I feel the first rib moving on both sides now. Still just a little stretch on this right side, but I'm okay with that. I'm going to add in a little bit more for the scalenes and that first rib area by treating Erb's point on that side, which is about halfway. Posterior border of the sternomastoid, about halfway. You'll feel maybe a densification of the skin. Oh, yeah, I just feel it right there. I'm just going to do a simple skin lift. I'm going to side bend to that side to loosen things a little bit. Bring it in the direction of ease. Little skin lift. And hold on to it and kind of move it in the direction of ease, like the way the skin wants to go, so it doesn't feel like a stretch. And as I do that, it just starts to kind of let go. And I might add some head movement. You can either move, it's like cupping, right? You can put the cup on and move the limb, or you can put the cup on and move the cup. So once I feel like I'm bored or I've done enough, then we recheck. So much better. Now, I've made a change in the cranial pieces. So let's look now how it relates to the arm. And there's a lot of ways we can check, but just easy one, flexion and supination. Alrighty, you can see big difference. Better range of motion. And then we want to go crazy, we can do some nerve testing. I'll move the camera. It's definitely an episode that you're going to want to watch instead of listen to. Down at the side. Oh, so much better wrist extension. And then I don't feel, this is so much better. I don't feel the tension. I feel, in my hand until about 85 degrees of shoulder abduction. Whoa, that's a huge change. And then we can go ahead and see, I'm closer. Now that's intense. It's way easier even on my right, even though my right wasn't the problem, but the fact that I can even kind of get there is huge. Okay. The other thing too, let's just look at the carrying angle, because that's something that people don't look at a lot, but I love to look at. So improved, still a bigger carrying angle than on my right hand, but better than we started. And so now I'm like, okay, I feel like we can start addressing these entrapment sites of the ulnar nerve on the arm itself. Now, I didn't even say too, like I had a very aggressive positive Tinel sign, which is when you tap on the area, and already the skin sensation and the Tinel sign is decreased from when we started this video, which is nice. But we're going to just quickly treat all the other areas and see if we can make things even better. So cocoa butter, my favorite skin medium. Cheap, smells good, long lasting. And tool of choice today, I've been using the wave tool. I really like it. I'm going to start at that area of the ligament of travelers. I'm not trying to kill myself here. Just to create a little vibration of the tissues, some shearing, just a little bit of work. And then I'm also going to do biceps. Biceps tendon, especially attachments. All right, that's our main supinator. Going to be gentle over that arcade of Struthers. The nerve's more superficial there anyway, so you don't want to irritate it. Going to do that that pronator aponeurosis area. Then we're going to do supinator and brachioradialis. This is very tight, but it's been feeling better and better the more I do this. This is my third treatment this week on myself. Then I'm just going to do quick on the flexors, but especially along flexor carpi ulnaris. Then we're going to go to the palm, that palmar aponeurosis. I like to do kind of like a twisting technique on it and fan the thumb muscles as well as the hypothenar muscles and get the carpal tunnel. Now, I'll give the extensor side of the radialis, not radialis, the ulnaris muscles too. But that's it. I do not scrape on the hand itself where my symptoms are because I have such a crazy Tinel sign. And already, like again, if we're rechecking that, so much better even from the last treatment. And then we'll recheck our orthopedic things. So, carrying angle first. Better. Still limited, but better. And then wrist extension. Getting better. with shoulder abduction. Now I'm to 90 degrees until I feel it. So I got a little bit more range of motion there. Still really good on flexion and supination. I'm still lacking a tiny bit of pronation and flexion, but so much better. And then I can almost do it. And oh, there we go. Now it just feels like a finger stretch, not a nerve stretch, which is nice. So the last little bit I'll do for it, because the nerve's been irritated, sensitized for so long, I've been finishing treatment by putting a little bit of topical anti-inflammatory / analgesic on it. And currently I'm using, it's like whatever I have in my house that works. But currently I'm using the Fringe CBD lotion, whatever it's called. I don't even know, but that seems to be helping as well. So that's it. That's all I'll do today. And if it's anything like the first 2 sessions I did, it's probably going to help quite a bit. And we'll recheck the next time. But hopefully that gives you some insight into what I mean by it's not in the upper extremity first. The most dramatic changes was when I did all the cranial and first rib things, which is crazy, right? And I know that's where my problem is, but yet I still want to go to my forearm all the time, which is like, no, the forearm is a piece of it, but it is not the piece of it. And so you always remember, you got to follow where the body wants. When we follow where the body wants, we get better results. And just like full disclaimer, the last 2 treatments I did, I haven't been doing such a good job of following where the body wants. And now today I'm like, God, that was dumb of me, because this is like the best wrist extension I've had in literal ages. So will the cranial tension come back? Yeah, more than likely, because guess what? Tomorrow I'm getting a cavity filled on that same side. And the nerve from the original thing is still irritated. And then also I've got 2 crowns and 2 areas of decay on the other side too. So yep, I'll probably still have quite a bit of cranial tension I'm working through because of unhappy teeth. But it's nice to know tools to be able to start there. And then also nice to know that that's part of what's driving this in my hand and wrist and arm, not the hand, wrist, and arm itself. So I hope you enjoyed that. Everybody always asks me, like, I want to see one of your sessions. I want to see how you treat people. Here's the thing. That's why you come to an in-person course. In the in-person course, I do demos. And so you get to see this in action. I will never probably have video of me treating my athletes or my clients, because they're well-known people and they don't want their healthcare all over the internet, right? And then same thing with the other group of people I'm working with right now, like Navy SEAL candidates. Like, yeah, nope, not gonna put their pictures and videos all over the internet either. So getting to watch me treat myself, I hope that was helpful. And then, like I said, yeah, that's the difference between an online course and an in-person course. Is in the in-person course, you get to see me treat somebody, and that somebody may be you. I pull from the audience. Anyways, have a great day. We'll see you next time.